Hello, my name's Julian. Welcome to The Secret Mind. I was going to do a review of the first month of the channel and see what needs to go, stay, be deleted, never be revisited again. But I've had on my mind for a while to just look at a Newsnight report from last week, because the future of some of the things I want to write about for the public and for doctors in particular, which will have a different approach to it. I'm not quite sure what approach to make. I'd like to almost use the same process, but with perhaps two different messages to different groups to make it accessible for everybody. Ultimately, doctors want to make people better, but they don't want to make mistakes. And medical error is very easy to do. And this was a report on last week's Newsnight. Actually, this is how long it's taken me to get around to it. It was on the 20th of January. So I'm going to play bits of this on BBC iPlayer. I think I can do that under fair use. I paid my license fee and I'm going to comment on it. I haven't watched this all the way through, although I know the gist of the story and I know the gist of 1,000 other stories like it. There is some further evidence that the BBC programme has got its report from the coroner's report, and there is a fairly straightforward story which has a few points that I think are useful for everybody to know. So I'm just going to do this live because I would like to prepare it more, and I will prepare more on this topic. It's a very common consultation for anybody in primary care, and you'll be able to see the way the story unfolds. You might note, as I do, when I hear of friends and family who go to doctors or talk to doctors or 111, is that process, not just frequently, I would say, but usually goes less than imperfectly. Poor communication, poor result, questionable scattergun diagnoses made, contradictions, a lot of waiting around. There's all sorts of reasons why this goes wrong with what really is considered sometimes fairly straightforward medicine, that if examined by somebody who's got the suitable experience and training, I don't mean going on a workshop or a weekend, I mean having trained within that specialty for some time, then these sort of things you would hope are avoidable. Obviously bad things happen, rare things happen rarely, infrequent things happen infrequently, but we're always looking out for those things. So we have to spot them when they're there, if we're given the opportunity. So I'm just going to play this program, and then I'm just going to comment on it as we go, if I can work out my own technology. It won't be as slick as I would like, it won't be as succinct as I would like, and I haven't seen all this program before, and the relatives of the unfortunate man who died are going to comment as well. So, but I am going to try and pull out the lessons from the emotion, if we can, and point out what I think is perhaps at fault in the process, on all sides if necessary. So here we go. I'm going to flip over to this screen now.
Good evening, this is David Nash. He was just 26 when he died after 4 telephone GP consultations over 3 weeks in autumn 2020. An ear infection wasn't picked up, and that simple infection caused an abscess on his brainstem. Last year, Newsnight investigated his case. Today, after a long legal battle by his family, an inquest concluded that he should have been seen face to face, and if he had, he'd probably have survived. Here's David.
Nothing can bring back David Nash, but for his parents Anne and Andrew, a long fight to get to the truth of what happened to him is over.
We in turn have spent 2 years seeking answers on his behalf, and to make sure that others don't die as David did. We know that is what he would have wanted.
Today's conclusion at Wakefield Coroner's Court that otherwise fit and healthy 26-year-old David Nash should have been seen face to face by his GP practice, and on the balance of probabilities would be alive today had he been.
Thank you.
Thank you very much.
David had 4 GP appointments with 4 different clinicians in the autumn of 2020, all of them over the phone. Today, the coroner concluded that not seeing him in person on his final appointment was a missed opportunity. In September, Newsnight investigated David's death. We obtained recordings of his consultations with the GP practice. They make for upsetting listening, but David's family wanted them played so that people could hear what happened to their son in his own words.
You're sounding like you're feeling a bit sorry for yourself. You're feeling a bit rotten.
I'm just not sleeping with it, and I'm not. Yeah, I'm just not myself with it.
Yeah, not sleeping very well. Are you eating?
Yesterday I didn't eat too much. Yet again, it just hurts to get up and do stuff with it.
By this 4th and final call, David was so ill, he was slurring his words, he wasn't sleeping, he was in extreme pain and couldn't eat. But still, he wasn't seen in person. Over the course of 19 days, a simple ear infection in an otherwise fit young man, which doctors say could and should have been easily treated, spread to his brainstem.
So just to stop it for a second there, let me put that up there. I think, looking at the coroner's report, that was a nurse practitioner he was talking to, who actually sounded quite kind and sympathetic and must be utterly mortified. My thoughts always go to these people because there, but for the grace of God, go the rest of us. But, and was also, although maybe the phrasing of feeling sorry for yourself was a little ugly, it seemed to me she was looking for clues towards low mood, and it was often you do that, and you were asked to look for depression and anxiety, and when we're looking for those things, we can avoid the major symptoms. But if you distill a case where it's the 4th consultation for something, and it's very easy to perpetuate what's gone before in the 3 previous consultation, if that's been fairly benign, seemingly, and if no examination has been required. When we see the coroner's report, some of those consultations were by doctors who seem to have decided no examinations required. Now, I have a certain problem with this. I should just say, for a disclaimer, I don't do clinical work where I can't examine patients. I'm not saying there isn't a role for telephone calls. It's become extremely popular. I think perhaps initially in follow-ups, in clinical reviews, they can be very useful, very quick, useful for people, particularly if combined with video, perhaps, which by the looks of it, this wasn't. And but my preference is there is a process to medicine called the clinical method, which takes some years to learn, and it's not secret. But I'll tell you a story of I was training some medical students a couple of years ago, maybe before COVID, so maybe a bit more than that, and we were discussing a case, and I was saying, well, here you are, you've got the patient in, you've got the rapport, you've smiled, you've introduced yourself, you've done all the things you're supposed to do, you've taken the history, you've gone through the presenting complaint, the past medical history, you've talked about medications, allergies, you've talked about social circumstances, so you have an understanding of who they are, if they have a dog or a parrot, or you've discussed any allergies, and you've come up with a differential diagnosis. That's a group of possibilities that the medic, doctor, is what I'm really talking about. This is a medical process. Is then going to sift out, spin down to your favourite diagnosis, your one that you're most concerned about, or one that's most likely, or a combination of both. You've dealt with the red flags. You've then maybe discussed treatment options. You've given the treatment options to the patient. They've decided on one. You've checked you're okay with that, and they're not making a terrible decision. We can talk about that at length later, but ultimately patients have the choice. They just need to understand some options for treatment may be much more favourable than others. And then you've discussed the evidence of why you feel this way, why you think they should be compelled to take a treatment X for this instead of treatment Y, or no treatment at all. And then you've tried to explain that as best you can, explaining evidence in simple terms to patients isn't that easy. They can come with very, very fixed ideas of what they've read on Wikipedia, which usually is probably going to be right, or Google, but that doesn't mean in their particular circumstances one approach is going to favour over another, because Wikipedia won't tell you anything about that. So you've done all that. So I was talking to these students saying, you've done all that, you've come up with a differential, you've made your diagnosis, your working diagnosis. It doesn't have to be perfect, doesn't always have to be correct, but it's backed up as best you can. We're dealing with an art, not a science. So there will be imperfections, and then you've discussed it with them, you've checked their understanding. This is every consultation we're talking about. This is just the way consultations are done, right? So you've checked the understanding, you've done the treatment, you've informed them of any side effects if prescription, for example, is involved. You've given them hopefully some idea of prognosis. Now that isn't easy. Predicting the future isn't easy, but you've done that to some extent the best of your ability. I mean, you'll often get a question, how long are we going to get better, doctor? Oh man. So you're probably going to have to fudge the answer to that one a little bit. Give a note of optimism and hope, but then you've got to safety net. Safety netting is very complex for doctors. The work I want to do on that is probably going to be directed mainly at doctors first, because it sounds easy. It's very complex. Often it's done, therefore, very badly. And somebody says to you, if you get worse, go to A&E, which is useless advice. It's almost impossible to imagine exactly even what it describes or means in your particular circumstances. But you've got to bear in mind, medics and health staff in general are very keen to cover their back for obvious reasons. Minor things that present and appear minor can turn into tragic consequences. And the people involved will remember these cases for the rest of their lives. And the people who have had the conditions don't even get that option. So it's serious. So I got to the end of that thing and say, does anybody know? These are medical students learning the medical method. So does anybody know what I've missed out? What has been missed out? I've told you how to assess a case. Does anybody know what's been missed out? There must have been a dozen. It was a small group workshop. Went down the entire line. No, 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 no. And I said, what about clinical examination? Nobody examined the patient. And they go, oh, yeah. Now, history, examination, they're the two things you do. That's the process. And yet one of them, for I think they were probably fourth year medical students, had just been totally missed by all of them. And it hadn't felt out of place. And that lived with me. It does live with me, because there's something wrong, isn't there? I'm not saying they're not taught examination, but for some reason at that point there was so much to do, perhaps in the way I'd described taking a history. They know that it takes 45 minutes to take a decent medical history, or a comprehensive one at least. Psychiatrists would take a lot longer, and they're only dealing with mental health, never mind all the other systems of the body. So it seemed to me that it wouldn't be such a big leap for medical students or future doctors to actually be okay with not doing the examination, having done all that other stuff. And you don't have to go in very far in general practice to realise that's exactly the case. So if you're feeling faint and you phone up the doctor and they can't measure your blood pressure, and you can't because you don't have a machine, I mean, it's obvious, isn't it? Your blood pressure needs measuring. It's going to have to be done by somebody somewhere. Isn't that obvious? It must be obvious. So when you collect clues, the story changes, and you find the clues early enough. So that would be my thoughts on that. It sounds like it was 4 consultations. That was the final one we heard. It sounded like somebody who was being sympathetic and getting drawn down a certain track of maybe looking at how he was psychologically feeling instead of thinking the basics of, has he phoned 4 times with the same thing? Now, what you'll find from the coroner's report, that he hasn't. That is not 4 times with the same thing. There is a twist in this tale that is something else that can derail you unless you've got your clinical method on. Let's just play on, see what happens.
All right, David.
All right.
All
Bye.
right, love. Take care. Bye-bye.
Bye.
Bye.
2 days later, David Nash was dead. David's GP surgery, Burley Park Medical Centre in Leeds, maintained for the last 2 years that the care they gave him was appropriate. But 1 week before the inquest, the practice finally recanted.
As a practice, we accept that David should have been seen in a face-to-face appointment on the 2nd of November 2020 and wish to apologise to his family and friends that he was not dealt with in that way on the 2nd of November.
But what did and didn't happen here at Burley Park Medical Centre may never have been rigorously questioned had it not been for the efforts of David's parents. Newsnight can now reveal the battle that they went through to ensure the question of face-to-face care was even considered within the scope of the inquest.
The fight began in April of 2021. The coroner's court appointed a GP expert who concluded that the care David received from the GP surgery was appropriate.
There is no point when, in my opinion, the symptoms indicated that Mr. Nash should have been seen by a GP face-to-face, been advised to attend at A&E or some other course of action.
Although this assessment was eventually withdrawn, it was not before David's family felt obliged to hire their own experts at great expense and involve NHS England, who looked into the case and concluded,
given that the deceased had consulted on multiple previous occasions and in the absence of a definitive diagnosis with worsening symptoms, a face-to-face assessment should have been offered.
And for NHS England's expert assessor, the requirement of a face-to-face consultation wasn't a matter of judgment, but a clear obligation.
It's been hugely difficult, and I think the fact we got no recognition from the practice until literally this week made me feel that if there was no apology, there was no recognition, therefore there would never be any change. So it's been very protracted by certain events.
The family are concerned that although the pandemic is now over, there are still not enough face-to-face consultations going on nationally. According to the latest NHS England figures, 7 in 10 appointments are in person.
The whole point of an inquest is to identify where things have gone wrong in order to prevent future deaths. So the only positive lesson that can come out of this is adding to the debate of lack of access to GP face-to-face appointments. David's GP practice have learnt from this tragedy. I wish that other GP practice would learn from this tragedy and not experience their own tragedy in order to then learn.
So he looks very genuine, and that's what he really wants to do. So let's try and get that message out to him as well, and probably we all have a responsibility in doing that. But yeah, that this is saying that 7 out of 10 people were seeing face to face. That sounds not too bad. I've certainly got the impression that it's a lot fewer than that. When they're the people who can get seen at all, of course. Most people I hear get deflected to 111 calls, even in daytime, Monday to Friday. So even when your GP's open. So I think there's a big spectrum of stuff. There's equally a lot of people who have no difficulty getting into their GP at all, and the GPs work very hard on triaging their own calls. I have a slight, not bias, but where I sit in A&E, I get the people who have been safety netted. Oh, anything goes wrong, just go to A&E. Or lots of people who can't get an appointment with a GP, lots of people who can't get through on the telephone, lots of people who phone 111 and found the results unsatisfactory, or have just been told to join the queue in A&E. And I work in a place where our setup's pretty good. So clearly there's a lot of variability, and people have to sometimes fight to get through the systems and have your symptoms heard. So let's just carry on.
Can now remember their son for the person he was rather than what he suffered.
Let's talk now to Dr. Rebecca Rosen, a GP and also a senior fellow at a healthcare think tank called the Nuffield Trust. Dr. Rosen, thank you very much for talking to us. What do you take from this awfully sad case?
Well, first of all, can I express my condolences to David Nash's family for his tragic death? I think they're absolutely right to say that we need to, at times, bring people in for face-to-face appointments. We are up to 70% now, and that is possibly the right kind of percentage, but we have to get the right people in for the face-to-face appointments and to know when somebody has to be seen face-to-face because the telephone won't do.
So, yes, so she's agreeing that 70% doesn't sound too bad in this day and age, particularly if it's a video telephone. Surely that's a much bigger advantage. What you might have to ask, though, she's talking about the right patients, also the right people making the call. If somebody's called 4 times in a short period of time, is that appropriate to be responded to by a nurse practitioner as opposed to a doctor? Well, surely we should elevate the process to a level of medical knowledge, because that last person in the queue is under a lot of pressure, and it's very tempting to repeat the hold the line for the end point of the previous consultations, which of course this was no face-to-face consultation offered. So we need to support staff as well to expose the nurse to that if there was a system in place that would avoid that happening. Triage isn't easy. It's minor symptoms are not easy. There's a myth that minor symptoms are easy. This is why they're not easy. They're difficult, and they should be done by the most experienced part of the team, not people with no medical experience, but with nursing experience. That's not to say people don't know to be on the lookout for mastoiditis, but nobody was trained to do this over the telephone. If you're going to take those sort of risks, you need to have a higher level of qualification. I think that's probably a medical qualification at that point. Not a pharmacy, not a nursing, not a paramedic, because who wants this hanging over them for the rest of their life? And who wants the result that it delivered for the family? It's not to say things couldn't have happened that way anyway. Overwhelming infection can happen very quickly. But somebody on the report speculates that an earlier intervention would have helped. These weren't typical times during COVID when people are denying face-to-face operations, but the story is typical down the years of if somebody ends up killed by an illness, there's usually been some steps before that in an ideal world somebody would have predicted the future and spotted it. It isn't always that easy. It really, really isn't. But that means your paperwork has got to be bulletproof, and so have your systems when the coroner comes knocking. So I'm looking at this from the side of the medics and the nurses, and obviously the side of the patients and family, and we need everybody to be supported and correct as correct as possible.
So I'm part of a research team called the Remote by Default 2 study, which has been looking at the switch to remote consultation in general practice. And we've identified a few ways that we think you can improve the safety of remote consultations, of telephone consultations. And they include, for example, at the point where people phone in, getting better at the quick assessment and decision about who should be seen where. So triage, what's called triage.
Yeah.
Right. So instantly, that is a very simplistic thing to say. To get better at doing it, you have to have had experience at quite a wide range of medicine, because what's happening at the moment is that people are faced with endless, largely irrelevant questions, which wind them up, put them off, and disenfranchise them. And they don't make them feel heard, which is why they often end up at the emergency department. But we can get a bit better isn't good enough. Of course, you can create another spreadsheet, another form, but you need people who are properly trained. This was an ear infection. The idea that the the specialty of ear, nose and throat, it has its own specialty, that we don't need to examine ears. I mean, try and say that. I don't know how many ear, nose and throat surgeons, because it's a surgical specialty, would be sympathetic to this at any level. Because if you look at the evidence for prescribing antibiotics generally on simple ear infections, it's 6 and 2/3 whether you do or don't, in which case they're largely better deferred. In this case, that's not the case, but you've got to find those cases.
And I think very importantly in David's case, promoting continuity. When somebody's been seen several times, making sure they're assessed by somebody who's met them before, because they probably would have noticed that his condition was changing and deteriorating. It wouldn't have just been a set of isolated consultations with people that didn't know him.
Yeah.
Well, that was impossible in this case because nobody had met him before. They've spoken to him, but the rule is do your own follow-ups. Follow-ups are usually designed so some other lucky fella has to pick them up. And it's difficult doing somebody else's follow-up because everybody does medicine differently. For your follow-up as a doctor to be done by a practice nurse, who would vote for that being appropriate? Do your own dirty work. If you set up a follow-up, if you want someone seen, you see them. If you don't have the skills, phone somebody who does. But don't leave the patient in limbo. Knowing them is something that is historical in GPs. So there's a romance in GPs that you know your patients. And increasingly that isn't true, apart from the fact people can shop around so many places. That knowing them, so she doesn't mean knowing the patient. Patients often come in expecting you to know them because you have access to their notes. You don't have time to read their life story before they walk in the room in a 10-minute consultation. You wouldn't have time to see the patient and talk to them, let them tell you what's wrong with them. So that is it's a little bit of fudge there with the idea of knowing that she used there. Is it knowing the patient? She's not really, she's sort of claiming so, but it's knowing the symptoms and knowing what's the most serious outcome that you're trying to avoid. Look at it, what's the worst case scenario? And when you see how this guy presented, he doesn't present in a normal way just with a little tingle in his ear. He presents with lumps in his neck, much more dramatic than we hear on this part of the story so far anyway.
Yes, he had four telephone consultations with 4 different clinicians.
Yeah.
The Royal College of GPs themselves said last year that they thought perhaps remote consultations had gone too far, but it was COVID, there were restrictions. You're saying it's back to 70% face-to-face. Is that what it was pre-COVID? Are we back to normal, essentially?
So it varied between practices. Some were lower than that, some were almost 100% face-to-face. And the crunch is, how do you decide who should come in? So that business of listening really carefully to what people are saying, picking up the distress, active listening, knowing when people are saying, this is not right for me, and then bailing out, saying, you've got to come in.
Yeah.
It's very important to know how to do that. And you know, we're learning, and we probably need more training about how to do that.
Yeah. You can always need more training. Every paper in every medical journal that has a vague result will say, and more research is needed. It's used as a comedic line. We need more training. You need to come in with the correct training into these processes. Medical training takes quite a long time for a reason. Partly clinical examination, that is this thing that has been sidelined here, it takes actually quite a long time to learn. You're learning from an awful lot of experts. You're examined to a very high degree. Just examining a joint in the body, you could spend 20 minutes doing a shoulder alone. A neurology examination could easily take you 45 minutes, easily. So in general practice, all sorts of compromises have to be made, but that's when accumulating consultations. Even in general practice, if you had 4 consultations of 10 minutes each, you could do a comprehensive neurological examination. If I don't mean on this patient, but if it was somebody with neurological symptoms. So you can do a bit at a time sometimes. In here, it was a different priority, but those consultations accumulate. So it's not just 10 minutes as a one-off. I must cure you. The great privilege and power of general practice is you can see people again. Not if you're seeing somebody different. You're always starting from scratch. And the doctor has an extra problem of interpreting the opinion of the previous doctor and trying to marry it, make it not confuse the patient, which isn't always easy because sometimes you might not agree with that other doctor, and giving them a plan forward. That plan for being if they see you or if they see somebody else. Emergency room, I'm seeing people in primary care, but they shouldn't be seeing me. They should be going back to their own GP. So I'm trying to provide a set of information that won't contradict anything their GP does, hasn't contradicted what their past, unless I have to give a very different view on things. But the patient, as long as the patient is empowered to know what they need from their next consultation, in the same way, that'd be nice if they told them what they need from this consultation as we start it. Sometimes I ask, sometimes I don't. It can be a difficult question to bring up.
We know that everybody knows that GPs are really, really, really stretched at the moment, and that recruitment is a problem and that retention is a problem. Is there one thing, if I could give you your wish and there was one thing that you could sort tomorrow, what would it be?
Gosh, there are so many things. More workforce would be absolutely critical. I think we could do better at actually using data and using technology and using things like that to really spot people in David's situations who have come 2 or 3 times, rather than it being a random decision who sees him next. There are computer algorithms now that could ping an alert to us and say, this person, has come 3 times in the last 3 weeks. Somebody needs to pay serious attention. So that's something else that we could do. And
where do I start? I'm going to.
And through our research, we've said actually just quite simple things, developing rules of thumb. We've suggested 3 strikes and you're in. If you contact your practice 3 times and if you're asking about the same problem, you must be seen in person.
I've got a rule for you. Try and get it right first time. How's that grab you?
So there are some very simple things, some more complicated technological things, and then the really big crunch, which is workforce.
Yeah.
The answer to this is not technology, for anybody confused by that. And if you work for a think tank like she does, maybe there's some advantage in that. But the advantage is to do clinical method well, to be able to do it even when the internet goes down, even when there's a power cut, when you've only got a torch and the will to see somebody and examine them and look in their ear, examine behind their ear, look at the lymph nodes. Come on. I mean, do the basics well. Let's not get into too much AI and chat AGT or whatever it is. We can just do the basics well. The clinical method works, but nobody needs more algorithms at the moment. That's not going to help patients like this. Right, so that's that. So let's just do this. Excuse me a second while I turn the lights on. Alexa, screen on.
Okay.
That's a bit better. It's very sunny out there. Spring must be on its way. So let me just show you how this story plays out a little bit. This is a news report from the Post. That's the Leeds. I can't even read the print of the Post. I would have thought it'd be the Yorkshire Post, but it doesn't look like that. A neurosurgeon says Leeds student would have lived if he'd gone to hospital earlier on. Well, I think you could probably say that for most things. And they just describe this incident. The coroner had heard a GP expert conclude that the advanced nurse practitioner who spoke to Mr. Nash should have ordered an urgent face-to-face appointment, and it's likely this would have meant a hospital admission 10 hours earlier than when it actually happened. But she hadn't picked up on that sense of urgency, and she wasn't talking to a panicked person. She was detecting something else. She was obviously a sympathetic, empathetic person, and her attention got drawn down a different line. The court had heard how Mr. Nash and his partner instead made a series of 5 NHS 111 calls during November the 2nd as his condition deteriorated before he was taken to St James's Hospital by ambulance. He was transferred to LGI for neurosurgery but could not be saved and died on November the 4th. He developed mastoiditis in his ear, which can cause an abscess on his brain. Mastoiditis, not common, but everybody knows to look for it. These stories with mastoiditis, there'll be several that you can find. It's not eradicated in the UK. It is something that happens from time to time. You're always on the lookout for it. And clinically, if you examine for it, it can be very easy to suspect and act on, except over the phone. On the balance of probabilities, had this intervention been 10 hours earlier, his death would probably have been avoided. That's very specific, isn't it? Doctor said he did not criticise the remote nature of Mr. Nash's first 3 consultations. Now they were on October the 14th, 23rd and 28th, so that's quite some time before. But he said Mr. Nash's presentation of fever, neck stiffness and nighttime headaches on November the 2nd were red flags, and the nurse's diagnosis of a flu-like virus was not safe, despite the fact that it was COVID and a flu-like virus was rampaging its way through the world. So the parents campaigned to find out whether the mastoiditis he had developed would have been identified and easily treated with antibiotics if seen face to face. The inquest also heard that Mr. Nash fell while left unattended in a confused state during his time in the emergency department at St James's and cut his head. I mean, that's just mentioned briefly in another sentence, but what can you say? I mean, you've got somebody confused who, I don't know, climbs off the bed or something, falls over. You've got another injury to sort out. In his report, Mr. Howarth concluded that this had no clinical significance in terms of the outcome. It doesn't help though, does it? Gives you a clue to somebody who's even more confused. So let me just come out of that for a second, and then I've just got one other thing where I think probably the BBC report has got its information from, which is the coroner's report, which is brief and to the point, which is why I thought it was worth looking at this today. Sorry, the screens are sun is streaming in. And so let's put this up. So this is made on the 31st of January 2023 from the South Yorkshire assistant coroner, and they summarise the story quite neatly, and it gives you an idea of how these stories play out, and it's not a very long document. David died on the 4th of November 2020 as a result of a brainstem infarction, effectively a brainstem stroke, arising from a cerebellar abscess, missing an R, caused by mastoiditis. So an abscess in the part of the body that can cause balance and dizziness problems, so cerebellum, so very close of course to the mastoid behind the ear. And so on the 2nd of November there was a missed opportunity to direct David to seek face-to-face care during his GP appointment that morning. GP appointment, but was he seen by GP that morning? I don't think he was. I think, had he been directed to seek face-to-face or urgent care by the GP practice, it is more likely than not that he would have undergone neurosurgery approximately 10 hours earlier. Medical cause of death was brainstem infarction, cerebellar abscess, correctly spelt this time, and mastoiditis. So notice the way the terms GP and GP practice are used almost interchangeably, and that is an unfortunate pattern that has grown up recently. So he first spoke to his GP on the phone about some swollen lumps on his neck. So this isn't ear pain that he's presenting with, lumps on his neck on the 14th of October 2020. So that's quite a period of time earlier. He was advised he should have blood tests, and these were booked for the 2nd of November, 2 weeks later. So someone's got drawn down the pathway of how to investigate neck lumps within a fortnight usually, and they've gone straight for blood tests. It looks as though those neck lumps weren't examined, and neither was the identification of anything local, such as a point of infection, where those lumps could have been due to. And 23rd of October, we're now 9 days later, he sought further advice from the GP because he had pain in his ear. So now we've got pain in his ear and neck lumps. It's a different picture, isn't it? And was complaining of an ear infection. Well, that's a diagnosis that people make. You complain of symptoms. The ear infection is the diagnosis. At this time, a telephone appointment, there was an assessment for mastoiditis, and otitis externa was diagnosed. Okay, so there was an assessment for mastoiditis. We don't know what that was, but presumably it was negative. What could that have been? It's a telephone appointment. No sign of any video. So he's asked, presumably, to press behind his ear? Is that it? And see if there was mastoiditis? Is that good enough? Is that how we assess for mastoiditis? Maybe in 2020 under COVID, I wouldn't be happy doing that. Antibiotics, ear drops were prescribed. He's already got neck lumps. So putting the two together. He was then spoken to on the phone again on the 28th of 2020 because he felt that he had blood in his urine. He was advised to deliver a urine sample to the practice, which he did, and when tested contained blood and white cells, resulting in further antibiotics being prescribed. Okay, so that's actually a totally different problem. It's hard to relate the two together, a urine sample and unless he was becoming so systemically unwell that you can get microscopic blood and white cells, and it can be difficult to know what significance they are. If they're only minor, sometimes they don't have a very large, what's called positive predictive value towards disease. So on that alone, I think prescribing antibiotics is, I'm not sure what it's treating really. Anyway, let's see. The view of the GP expert was that this was unlikely to be a UTI, a urinary tract infection. However, there would be no basis on which a GP would link these symptoms to mastoiditis, and therefore the treatment was not unreasonable on this occasion. I'd go with that. I prefer to defer antibiotics in those situations until we've got... you could have sent it off to a lab and done that, but maybe pressures in COVID, I don't know. Some people just slightly overprescribe for potential urinary tract infections, but in young men, why would he have a urinary tract infection? Anyway, it didn't seem to have done much harm. Maybe that extra course of antibiotics in a more fortunate world might have cleared up his mastoiditis by chance. There's a thought. And if they did that, actually, if they gave him the antibiotic, realising that his ear infection was maybe not resolved, there might have been some actual good done there, just not quite enough. From the evidence of the ENT consultant, it's more likely than not that at some point in the days after this appointment, David began to develop the abscess that would ultimately prove fatal. So in the days after this appointment, okay, so maybe the seeds are sown, but the abscess came imminently now. On the 2nd of November 2020, David had a telephone consultation with an advanced nurse practitioner at his practice. He had continued fever, pain behind his eye, and sinus pain. Fever, pain behind his eye, and sinus pain. He'd had a negative COVID-19 swab in the week prior to this appointment, but nevertheless his blood tests were cancelled and he was advised not to visit the surgery, but to take a further COVID-19 swab and await the results. This clearly unsettled David, who was concerned to get his blood test completed, and the ANP gave reassurance that as soon as he had negative COVID-19 swab, she'd book him in for his blood test and see him urgently in the practice. That's an odd state of affairs, isn't it? So for some reason the blood test got cancelled. He had to do another swab. Maybe this is just the pressure of the COVID-19 and a little bit of... So he's waited 2 weeks more for these tests, and they've not appeared. Not that that would necessarily change. Blood tests don't make people better. And he was doing blood tests as a general look around his body for the cause of swollen lumps on his neck. They wouldn't have probably told him a lot in mastoiditis, apart from maybe he had a very high white cell count, which if it was very high might have alarmed them. but the blood tests weren't for that. The problem was he wasn't seen. He wasn't going. He wouldn't have been seen for a consultation, possibly even by just having the blood test. But for some reason, the blood tests were cancelled. As the 2nd of November 2020 progressed, David became increasingly unwell. This resulted in David's partner contacting 111. She explained his symptoms and was advised a clinician would call back within 6 hours. Unfortunately, David then vomited, so his partner called 111 again. Same advice. When a clinician did call... Clinician. Here we go. So a clinician. So before we had somebody called GP, then we had them referred to as a GP practice. Then they're identified as a nurse, and now they're a clinician. So I don't even know what a clinician is. To me, it used to be someone who was medically qualified, by which, for clarification, I mean someone who has trained at a medical school. But that is definitely used. The term clinical has been used by all sorts of beauticians and various things now. You said you don't know what you're doing. They might tell us in a second. I may have jumped the gun here. Unfortunately, David then vomited. When a clinician did call, David's partner was advised not to wake him if he was sleeping. Yeah, that might be fair enough, but it's always a difficult decision, that one, because you sometimes need to be able to prove people arousable. And to keep up to date with codeine pain relief. So needing codeine, not sure who's prescribed in that, maybe I don't know where he's got it from. That's not clear to me. About an hour later, David began to be disorientated. And his partner made a final there was a fever, so always handy to have a home thermometer when you're reporting a fever. Reporting how high it is might put a different sense of alarm into the practitioner. Might help. You need everything you can to present your case and get it through clearly to people. You almost need to know the red flags they're looking for yourself and phrase it with reference to them. And if patients become better at presenting their cases, it not just makes it easier for clinicians, it makes the route to the proper care could possibly be easier. Often it's not done with a little bit of, it might be done with a bit of research, but it can also be done with people being angry and shouting, which can tend to have the reverse effect. Not that that was here. David sounds like a very nice, gentle soul. Possibly that also meant it wasn't pushed as hard as his symptoms were bothering him. It maybe didn't get put over as strongly, despite all the evidence. Often you just see consultations in isolation. You're not constantly registering yourself. They've been seen once, twice, 3, 4 times before, whatever it is. They've phoned 111 once, twice, 3 times, 4 times, whatever it is. Things don't get wrapped together. Okay. So he's disorientated, and the final call to 111 results in an ambulance because all the questionnaires have then triggered. All these very, very late questionnaires that look for red flags is triggered, but they're not very good at finding it in the early stages because patients are undifferentiated. Their symptoms are grey. The lady doctor in the video there thinks more computer algorithms are the answer. I'm afraid I don't agree. We're not at that stage yet. We're simple, doing the basics of history and clinical examination by somebody who hopefully has done some ear, nose and throat training under ear, nose and throat specialists for a period of time, a few months. That would be the way to go. So David was taken to St James Hospital. He was triaged quickly. It's easy. The thing about a lot of emergency work is it's fairly straightforward what needs to be done when you're in extremis. It's the previous situations that are often extremely challenging and difficult. He was triaged quickly. A working diagnosis of either meningitis or encephalitis was made. Fine. That's encephalitis in itself can have a very high mortality. Meningitis, we all know, can have a very high mortality. You're at a stage where his life's in danger at this point. Both of these conditions will be treated at St James's. He required a CT scan, which is done within 2 hours. It's reasonable. This was within the context of an ED under emergency department under significant pressures. 2 hours is pretty good, really. A as soon as the CT scan was undertaken, it was apparent how unwell he was. Urgent steps were taken for neurosurgery. He deteriorated, suffered a fall resulting in head lacerations that did not contribute to his death, and unfortunately deteriorated, required ventilation, a drain, and died. So these are tragic, painful, difficult stories. There's things to be learned, and it's the basic things. To examine a patient and not do it by telephone seems to be the basic thing. I feel for the nurse who saw David on the final consultation, or didn't see him, and the practices of the practice didn't protect that nurse. And it is fundamental that somebody treating an ear infection without looking in the ear, whoever you are, however old you are, to me, isn't appropriate. I understand people may feel differently about that, and it was COVID. There were other extenuating circumstances, so you may have, even I may have found myself prescribing antibiotics to avoid a consultation because of the infection control aspects. But stories like this do replicate throughout the annals of time and medicine. This is a fairly classic, quite a succinct case that starts with minor illness that people think is easy. This is the reason it's not. So I wasn't going to talk about that today, but I just wanted to do that because it's not just that condition, it's every other condition. The search for the diagnosis, the difficulty of dealing with undifferentiated cases, the realization that minor illness is complex illness, and the assumption that's in society and in funding patterns that people are fine going to their chemist first when some situations do require medical examination. If you've got somebody with an ear infection, look in it. It doesn't take you that much to do. If you've got somebody who's feeling dizzy, do their blood pressure. It doesn't take you that much to do. You just might have to meet up with them, have a chat with a human being. I know there's pressures of work, but it's not an excuse. Look how much work was generated by not doing this. How much work it could have avoided within the system by doing one comprehensive consultation a little bit earlier, perhaps. Nobody wins. So I'm probably going to look at that for doctors before I do, unless anybody's particularly interested in this channel. I don't know if there would be. It's quite hardcore. It's quite upsetting. But we have to learn the messages. If we can't do it in a case that is as simple as this, then many of the other ones have much more complicated stories and scenarios behind them. So I'll sign off on that. I don't know if it's useful or interesting to anybody. I don't want to frighten doctors. I don't want to frighten nurses. I do want to frighten myself, because there, but for the grace of God, we can all go with these cases. If we're cavalier one day, if we just don't realise that, most ear infections are fine, most don't need antibiotics, that's true, but you've got to find the ones that don't, and you get an instinct. You can examine the ear, and then you can explain to the patient what you've seen when you examine their ear. And when you've done that, usually the conversation that you're having is why they don't need antibiotics. And you're saying, look, but that's more reassuring. You're not getting them to put false hope in a medication that isn't going to work, and that had you looked in their ear, you would have been able to prove that. You're not going to make them take 15 or 21 if you're still giving people 7-day doses of antibiotics. Generally, please don't, but if you are, for some reason, you're not asking someone to take 5 doses of antibiotics, because if they get the sense quickly you didn't engage with that, he didn't even look in my ear, why should I take these tablets? Then you failed in your consultation. You failed as a doctor. The patient is not full. The reason your patients aren't compliant with your medications is that you didn't complete that that consultation to anybody's satisfaction other than your own at the time. That's a failed consultation. You've got to try and minimise the number of those that you have. So I don't know how much of this is appropriate to put in front of the general public in YouTube. Nevertheless, it's important we all know both sides of the story. And this is a very simple story, and a very tragic one. Anyway, don't want to repeat myself. If you've got this far, well done. Leave a comment if you've got a comment. I'm not trying to upset anybody with this. I'm just, it's important stuff. Leave a comment if you would like to see more sort of explanations like this. I'm going to be doing them anyway. I'm just not sure how much to put on YouTube. But there's an aspect of education for all of us that we need on these things, and it may have a different flavour. Anyway, see you tomorrow.